12:15, so I'll dive right in for those who have joined us. We have a huge crowd here in Clopton with one other person. What was your name? Charlene Prather is here with me. I know there are a lot of residents getting food up in 7 Barnard. Thank you so much, applicants, for being here with us. And then I know some others will come in here to Clopton to watch this. But so excited to do CPC again today. These are our disclosures. I'm sure none of them are relevant to this talk today, specifically my overreading of the instructions at the beginning of my time here when I listed individual stocks that I own. Don't take any advice from me on this, but none of them are relevant to this. My financial interest in IBM has no relevance here. So we'll move on. So today is the case of a 24-year-old woman with asthma and environmental allergies who presents with cough, pleuritic pain, and acute on chronic dyspnea. And our expert clinician today is Dr. Murali Chakinala. I'll begin with a little bit of history of CPC and then a little bit of introduction for Dr. Chakinala, and then he can take over for a few minutes from there. So a little bit on the history of CPC. Why are you here today? What is this? Well, essentially, CPC is one of our favorite conferences here at WashU that has nothing to do with the Thai food that we serve concurrently. Not so much about finding the final diagnosis as learning the practices of being a physician. Originally, clinical pathologic conference began at Harvard. They got us there, where they took the idea of case reports from the legal field and applied it to medicine. It then spread from there around the country, and in the early 20th century, it was brought here to WashU, and you can see a picture here of the pit with someone leading CPC. The idea here is we have an individual expert, but also have some other experts. We have a radiologist here today, as well as a pathologist who will help us through the case. So a few words on our expert, Dr. Chakinala. So a little bit about him factually, the resume virtues, as you might say. He's a professor of medicine here in the Division of Pulmonary and Critical Care Medicine. He's the director of the Pulmonary Hypertension Center of Excellence and the co-director of the Hereditary Hemorrhagic Telangiectasia Center. He did his undergraduate work in economics at Duke University. Maybe he could help me with my stock choices. He did medical school at Vanderbilt, residency at the University of Texas at Southwestern, and then fellowship here. And I've started to enjoy reading patient comments about physicians, and I really thought this one resonated, that Dr. Chakinala talks with you, not at you. And I want to emphasize that in all the times I've worked with him on pulmonary hypertension patients, on our cardiology firm, our inpatient wards, it's been a wonderful learning experience. He's the consummate physician and educator, as well as researcher, and it's a privilege to work with him.
Getting to our case, I try to get a little bit out of the one-liner, but I've learned over the years not to make too much out of it. It's a young person with asthma, and it sounds like it's legitimate asthma here, a young person, environmental allergies, but we always think about in CPC what are mimics of asthma. But I'm going to kind of put that aside and take it on faith that Carl's being honest with me that this person really does have asthma. I think the thing that really jumped out to me when I get this one-liner is this pleuritic pain, not typically a symptom of asthma. And so I'm going to say a few words and maybe a very initial sort of differential and things that I'm going to want to be listening for during the presentation and the data. Then, of course, it's acute on chronic dyspnea. So the chronic dyspnea may just be related to the chronic asthma, but something else has happened here. So pleurisy is what I wanted to just have one slide to talk about and have maybe an initial differential. And, pleurisy comes from pleural irritation. Nothing fancy there. And it could be from a lung process or a pleural-based process. And some of the things that can cause pleurisy that might be pertinent for this talk is certainly not an all-exhaustive list, but as a PH doctor, I'm going to, of course, think of vascular problems, anything that can cause an infarction, like a pulmonary embolism, or some foreign material that's embolized the pulmonary vasculature, causing an infarction, would certainly cause pleurisy. Another big category would be inflammatory conditions or systemic autoimmune rheumatic diseases. what are now called SARTs instead of CTDs. A couple of the big ones to think about would be lupus and rheumatoid arthritis, which she'd be a little bit young for, but certainly lupus would be a prime candidate. Of course, we have to think about infectious processes like a necrotizing pneumonia, empyema, lung abscess, and then let's not forget infections and abscesses outside the chest, like subdiaphragmatic abscesses or in something within the liver that is really irritating the diaphragm and causing pleuritic pain. Malignant disease, of course, we think of mesothelioma, which I wouldn't expect in someone so young, but bony invasion of other parenchymal masses could be a possibility. And then a whole bunch of other miscellaneous category or miscellaneous conditions like, traumatic event that cause rib fractures, which obviously wouldn't be the makings of a CPC unless it's a clue for something else, but a pneumothorax related to her obstructive lung disease or a hemothorax. Something we see in our part of the country is fibrosing mediastinitis, and you can get vascular insufficiency to large areas of the lung because of mediastinal disease, and that can in turn lead to pleuritic pain and pleurisy. And then sometimes pericarditis gets mispresented as a pleurisy. And then again, thinking about things outside the chest, even pancreatitis can present as pleurisy. So these are some of the things that I thought of up front as far as causes of pleurisy, especially in a 24-year-old. So I'm going to stop sharing and let Carl take over again.
Great. Thank you so much, Dr. Chakinala. So we will begin here with the patient's history of present illness as they came here to our facility with a little bit of extra detail that was found. And then after we go through the HPI and some other introductory details, we'll have another chance to narrow the differential or broaden it. So for her history of present illness, she presents to the ED here at Barnes with dyspnea that increased over the last 2 weeks. It occurs at rest, and she awakes twice nightly with this shortness of breath, and she's been taking her albuterol up to 6 times a day. She also has this associated pleuritic chest pain. It's worst with her coughing and deep inspiration that radiates to her back and arms, and she's had some lightheadedness, specifically when she gets into the most significant coughing spells. She now has difficulty walking around the house without dyspnea. And a little bit more history, she first noticed cough, dyspnea, and tachycardia with minimal exercise about 1.5 years ago after she moved from Columbia, Missouri to St. Louis. At that time, she was diagnosed with asthma and environmental allergies. 5 months after that, she developed a COVID-19 infection and an asthma exacerbation. 4 months after that, she stopped her controller inhalers due to thrush. She also had some insurance issues. 6 months after that, and now 3 months prior to this presentation, she has had progressive symptoms. Give you a little bit more about her past medical history. So as mentioned, she has the asthma, allergies, and COVID-19 infection. No surgeries. On family history, she has 3 brothers with asthma. Her maternal grandmother has sarcoidosis and ovarian cancer, and her grandfather had a pulmonary embolism and a DVT. Her medications have albuterol, which she's adherent to. She takes Adderall. She's non-adherent to her Symbicort. She has a Mirena IUD. For her social history, she is employed as an event coordinator. She started this last month. She lives with her significant other and 2 cats. She has never smoked. She drinks alcohol rarely, and she denies any use of recreational or non-prescription drugs, and she has no exposure to asbestos, lead, or other chemicals. I'll go on to the review of systems before we have some time for additional thoughts. So she has no chills, diaphoresis, or fatigue. Most notably, she has a productive cough, dyspnea, nocturnal dyspnea. She rarely has blood-tinged sputum. She has this pleuritic chest pain and some palpitations when she's coughing. Sometimes her coughing is so intense, she has post-tussive emesis. She throws up just a little bit after a cough. When looking at her skin, she has no extensive rashes other than eczema. She has some headaches, and coughing rarely triggers some presyncopal or lightheadedness, those symptoms. And she has some environmental allergies, but no recent flare in those. She also has these other negative review of systems that you can read for yourself. So based on that, I know you had a fairly broad differential, Dr. Chakinala. When we transition to additional thoughts, what are you thinking about this? Are you changing anything? Are you looping in some more information? Does her family history or past medical history in this COVID infection lead you one way or another?
Yeah, you mind going back a couple of slides to that's probably good. You can so, I mean, really, the overall tenor of the case sounds very much like somebody with asthma. I mean, she's got a lot of symptoms, the cough, especially nocturnal symptoms, the triggers, and, she has cats at home. She also moved to the St. Louis area recently when this got worse, so it's possible some of the allergens in our area are different from central Missouri. So it really all sounds legit from what you're telling me for someone with asthma. And of course, she's not on the best of therapies right now. So, but it sounds like 2 weeks ago, something changed, and something acute that might be precipitating things. Could you go forward? The family history, I mean, of course, sarcoid and the vena thromboembolism history, those not uncommon conditions, so we'll have to file that away. But sarcoid was one of the things that in a young person with chronic dyspnea and exertion you always think about. But interestingly, sarcoid doesn't usually cause a lot of pleural disease. It does many things, but not as much like pleural effusions or pleuritic problems. Her medication history, she is taking amphetamine-based prescription-based amphetamine. So could that in any way causing any cardiac dysfunction? So that would be something to think about. It. We haven't really brought up cardiac disease, except for possibly, pericarditis being misconstrued. But otherwise, I didn't get anything else. But overall, it seems like this is somebody with legitimate asthma, not well controlled, not on controlling medicines, and potentially some new triggers in the environment where she's moved to. But I guess something infectious that she got exposed to 2 weeks ago could have triggered this. The post-tussive emesis, of course, makes us think of pertussis, whooping cough. So, it could be an acute exacerbation related to something infectious, and being at CPC, probably something a little more unusual, exotic as an infection.
Great, thank you. I'll move on to
And I
the
and I didn't get, sorry, just going to last night, I didn't get anything real in the history to suggest that she has like an autoimmune disorder like systemic lupus erythematosus or RA. So that's probably much less likely now in the differential.
were there some things that made that less likely, points of history or review of systems that led you away from an autoimmune or systemic autoimmune illness?
Yeah, just really the lack of other things. I mean, photosensitivity, skin findings or rash, arthralgias. Nothing else really was mentioned. And most of the acute symptoms that have been, or most of the symptoms that have been provided really could stem from her asthma and airways disease, I think.
Awesome, thank you. So we'll transition to the physical exam and some initial labs. So most notably here on her initial intake exam, normotensive, she was tachycardic to 103 beats per minute. Respiratory rate was a little elevated at 20. She was saturating very well on room air. And the rest of her exam was very normal. So she was not in acute distress. She had a regular rate and rhythm at the time of exam thereafter. No murmurs, no JVD. She did not have any lower extremity or upper extremity edema. She did not have any wheezing present, and her effort was normal in her breathing. And as you were pointing out, Dr. Chakinala, she has normal range of motion. She didn't have tenderness or edema or any swelling of her joints, and she was alert and oriented. On her initial labs, so nothing here in the chemistry that I'm going to mark in red necessarily right now. A CMP was done. We don't have a magnesium or a phos. Her CBC here, remarkably normal, and she has a normal diff. Okay. So
Yeah, and I think, I mean, again, just stemming off of her asthma, some of the things that are legends of CPC, and we frequently talk about for unusual cases, sequelae of asthma, things like vasculitis and ABPA. I didn't really even mention those, even the thought about it, but just because her diagnosis is not very long ago. And generally, some of those conditions tend to be in long-standing people with asthma. So the normal diff, the nor lack of eosinophils is helpful for me in that sense.
Great. So we'll now transition to the kind of fun slide here about what diagnostics you want first. And so here are the options. So we have basic imaging, an infectious eval, urine studies, advanced imaging, which we'll focus a little bit more on Dr. Raptis, our radiologist here. I know that there might be a chest CT in the works, Dr. Chakinala, but maybe don't dive in there just yet. We have some diagnostic procedures that occurred during her stay. Some cardiology workup, some room serologies, some immunology and pathology that will probably round out the case here. So anything you'd like to start with here?
Well, I'm a pulmonologist, so I think imaging is the next step here. So we can certainly start with the basic imaging and get a chest X-ray.
Great. Okay. So I just want to make a brief introduction that we have Dr. Jim Raptis here with us today. He's an assistant professor of radiology. He helps us with many CPCs. He is in the Division of Cardiothoracic Imaging and received advanced training there. And as we have a pulmonologist today, I just want to say Dr. Chakinala has first dibs on this next slide. But Dr. Raptis, please feel free afterward to dive in with some further comments that you want to point out.
I appreciate that, Carl. I like to, formulate my own opinions on these. So, okay, pretty impressive chest X-ray. So, first off, her not taking as deep of a breath as you'd like to see. So this might be because of the pleurisy. Her cardiac silhouette looks okay, but she has diffuse, fluffy infiltrates. Yeah, just like you pointed out, lower lobes, upper zones, and they're, sizable. I mean, in fact, in the right upper lobe, it almost looks like a mass right there, just to the left of where you are, Carl, a little further out peripherally, right there. Yeah. And then on the lateral again, she looks like you can see that nodular kind of appearing mass-like areas. And then one thing I want to point out also is that she looks like she's got lymphadenopathy. So right around the center there where you're, yeah, perfect. You can see some mass-like lesions, but that right there where you were just pointing to right around 7 o'clock there, Carl, that space should be clear. There's usually nothing there. And the fact we're seeing this soft tissue there, that's almost a giveaway that she's got something in the subcarinal space, whether it's a lymph node or a mass or something. But she looks like she's got significant adenopathy, as well as these airspace opacities in multiple areas. I don't see any pleural fluid, and the bones, I think look okay. I'll defer to Jim if he spotted anything there, but I don't see any fractures or osteopenia or anything like that.
And Dr. Raptis, do you have further comments to make on the study?
Yeah, I mean, I think his read is pretty appropriate. I would read it if I was in the chest reading room, is that there's multifocal airspace opacities, some of which, appear slightly more confluent, like the ones that Dr. Chakinala pointed out. Other areas are more ill-defined and maybe some interstitial opacities as well. In terms of the lateral chest radiograph, I think it is important to note there's no effusions in the lateral. Obviously, no pneumothorax that we see on the frontal radiograph. The hilar region is tough. Lateral chest X-rays are tough. She doesn't have the most impressive prominence of lymph nodes. Her PAs, you can kind of see on the lateral normal in size. There's no kind of donut sign, if you will, on the lateral chest X-ray, but she does maybe have some reactive nodes adjacent to those branched pulmonary arteries. Nothing terribly impressive, though, from that standpoint. I think the most impressive findings are in her lungs.
And Jim, I obviously will see a CT soon, but I'm just looking now back on that frontal. Do you see some cystic-like areas in that right lower lobe?
Yeah, those areas in the right lower lobe are tough. It looks like areas kind of that are spared, more so than definitely that I would call cystic.
Okay.
Great, thank you. Okay, so just while we leave this on the slide here, does this change your differential at all with these bilateral opacities, some of which are confluent, some lymphadenopathy that we see centrally?
Well, I mean, we talked about sarcoid, I guess, that kind of comes back in the fold a little bit, especially a 24-year-old. I also would want to make sure she's not immunosuppressed. Like I would hadn't thought about checking HIV, but I think we need to do that, even though there weren't any obvious risk factors. Um, the certainly still infection. Malignancy, certainly I had put it lower on the list, but you worry about something metastatic. You can see adenocarcinoma, that what we used to call BAC, that could take on more of a consolidative appearance, but this would be overwhelming disease for that. So but I think something still infectious would be high on my list. An autoimmune process. Again, I'm not by chest X-ray. It's a little hard to say that now. Some of these more nodular dense areas, a vasculitis, like an ANCA-associated vasculitis. She's a little young for many of those, but it's on the list too. So I think we're clearly heading towards a good quality chest CT, as you alluded to earlier, Carl.
Great. So we'll come back here. And as you mentioned, we want to do an infectious eval. I'll just mention that I was not able to find an HIV test, or at least there was no positive HIV test. In the ED, point out that they did a nasal swab that was negative for influenza A, B, RSV, and she was COVID-19 negative.
Could I ask what time of the year this was?
This was in February.
Okay.
Okay, and there were no blood cultures that were drawn at this time. Now, based on what go ahead.
Sorry, I was just going to say, now we have more testing capabilities with the pneumonia PCR as well, too, that picks up a lot of atypical pathogens. So I certainly would be interested to send that off as well, too.
Right. Okay, so do you think urine studies, or would you like to maybe rule out any cardiology disease? Because I think there will be a lot of meat here and some diagnostic procedures. You also had mentioned some rheumatologic diseases, and so we have some serologies there as well.
Yeah, I mean, again, it's lower on my list, but I certainly would send off a battery of serologies and ANA, probably an ENA, and ANCA and their subtypes. There wasn't much in the UA that made me suspicious and whatnot, and I didn't really I don't remember there was much sinus disease, but I still send the ANCA. Probably send an anti-glomerular basement membrane as well, just to round out the rheumatologic workup.
Sounds great. So I'll run through a few of those. The urine studies that they did, the urine was remarkable for being very normal, no microscopy there. Her urine point of care HCG was negative. And then to point out the room serologies, not all that you had mentioned were obtained, Dr. Chakinala, but just pointing out her ESR was 4, RNP antibody 1.1, SCL80 was 0.2, the C-ANCA and P-ANCA were less than 1 to 20, and then TTG was 4, and her IgA was 216.
Yeah, so really not much help, and surprising how low her ESR is, given that she's acutely ill and a lot's going on her chest X-ray.
Right. Okay. I know that there's a yearning for a CT scan. Would you like to go there next, or would you do any diagnostic procedures right now, or wait for imaging?
No, I think we really need imaging. You asked me about cardiac workup too. I mean, I'm not really getting a sense that there is a problem in that heart didn't look big on X-ray. She didn't have findings of heart failure. Her exam didn't have a rub or anything. So pericarditis seems less likely. And you also got now a low SED rate. So, I mean, obviously we get an EKG, and if the EKG is normal, I'm not sure I would pursue an echo right now. I think that might change, though, if we look at the chest CT, or like I said, if the EKG has some findings to suggest pericarditis.
Great. And just on that point, I just want to highlight to everyone in the audience and online, you're also getting education in high value care, which is probably one of the competencies that you'll get marked on. So Dr. Chakinala doesn't want to spend money on a lot of extra tests. And indeed, the EKG was very normal. You can see these results here, and no TTE. Always important. Much of what we do for patients can be led, as is being mentioned already, by focused history, physical exam, and then precise testing. So let's transition to this CT scan where I think we'll get a lot of work. So this is the high resolution chest CT without contrast, which was ordered. Again, I'll hand it over to Dr. Chakinala first, and then Dr. Raptis would love for you to add some comments as needed.
Wow. So we're seeing 4 different levels here from the upper left going across and then back down to the lower left. You can see 3 upper, mid, and lower. And throughout this, she's got this very impressive infiltration / consolidation. What's really striking to me is just this combination of ground glass with that peripheral interlobular septae that are really highlighted or sticking out. I mean, you can see these perfect hexagonal shapes there throughout both lung fields. It seems like it's going up to the pleural surface and touching it. Yeah, it looks the same in all the different areas. There are again no pleural effusions as we talked about. Then on the coronal views, much the same, maybe a little more prominent in the upper zones. And it's not really sparing per se the costophrenic angle. I mean, almost it almost has a little bit of a crazy paving look, but I'm just even with crazy paving, I'm not used to seeing such prominent lobular septae that is sticking out like that. So it's a very impressive combination of findings, but it just shows that her air sacs and all these areas are just full of material, inflammatory, presumably material, not just simple fluid, I would imagine. If this was pulmonary edema, you'd really expect to see some pleural effusions here too. Do we have the mediastinal windows too, Carl?
I think these are the windows we have. Dr.
Okay.
You notice anything on the mediastinal windows?
No, there was nothing significant on the soft tissue windows.
I don't know, Jim, what else did you pick up on, or what didn't I miss?
I think you actually summed the findings up really well. The predominant thing we're seeing here, and if you just kind of take any part of the lungs that look involved, you see smooth septaline thickening and ground glass opacities. You kind of hit on a buzzword of what we typically would call this, so I'm not going to repeat that without going too far with it. But there are some areas kind of geographic sparing. These are kind of patchy. There's some spared areas of more normal looking intervening lung, but the absence of pleural effusions is a significant finding as well. But you kind of hit it on the head in terms of the imaging findings.
So would you read this out as crazy paving?
Yeah, I mean, I would call this is a classic
Okay.
example of crazy paving. It's about as good as it gets.
Okay. Yeah, I mean, like I said, it's just these sharp demarcations in this, patchwork area. In the handful of cases I've seen like this, it just seems like the septae are sticking out or more prominent than I'm used to. But again, I haven't seen a lot of these. But when we see crazy paving like this, the first thing we as pulmonologists think about is PAP or pulmonary alveolar proteinosis. That's the classic description and finding. So, she certainly has chronic dyspnea and then acutely it worsened on top of that. So something these patients can get super infected at times. Mycobacterial infections, nocardia also can complicate their case. And so perhaps she develops something like that on top of it. But this is, she's ready. I mean, we really need to make a diagnosis, and bronchoscopy can aid in that with a good bronchiolar lavage and potential biopsies too, if she can handle it.
Great. Perfect. So we'll transition now to the diagnostic procedures. A bronchoscopy was done the very next day. So I'll point out the read on the bronchoscopy and then some of the studies that were sent. And then we have pathology as well. So I won't necessarily read all of this out from the text, but essentially a very normal gross examination. Would you expect a normal gross examination on this patient, Dr. Chakinala?
I don't think it would be that unusual, especially for PAP. And again, if something infectious, this could be an atypical sort of viral even. So the lack of airway findings wouldn't dissuade me.
Gotcha. And just pointing out some of the studies that were sent here, there was a positive MSSA with 10,000 to 100,000 colonies per mil on the aerobic culture, but the rest of the cultures that were sent were negative. And I'll simply point out here that she also had PFTs done while she was admitted. So I'll just put these up on the screen here. I'm not sure that it will be too relevant for the case, and you would probably expect these PFT findings based on the CT you saw.
Yeah, so her both her FVC and FEV1 are about 56% predicted. So down kind of in a symmetrical pattern. Her FEV1 to FVC ratio is somewhat high, 87%. And so that suggests that this is probably true restriction and increased elastic recoil. Now, now that we know the imaging finding, it certainly could be from this airspace filling process, but keep in mind with her pleurisy that she was complaining about, if she, even if without the parenchymal findings, the pleurisy could mimic this as well. But in this case, it sounds legitimately related to this diffuse airspace process.
Great. So I think now some of the testing that was sent, we had some cytopathology that was sent out on the lavage. So I'm going to hand it over here to Dr. Morse, who's one of our fellows here in cytopathology. And I think I gave you the control.
Oh, there we go. Hopefully you can hear me. Thanks for allowing me to join today. Sorry, I don't have a camera so you could see my face. I was going to use this opportunity to go over how we process different samples in cytopathology, but for the interest of time, I'll just skip over this. But I think many of you know cytopathology is a branch of pathology that you're looking at individual cells. And in this case, this patient had a BAL, and this is a example image from the patient's specimen. And the main thing, of course, that you're doing with the BAL is you're using fluid to get into the distal airways and removing some of the cells. So it's an example of exfoliative cytopathology. And something that we use in cytopathology, of course, is making sure we have an adequate sample to make sure we can make a diagnosis. So the thing that we generally want is something atypical in the BAL, but the kind of bare minimum we want is to have these pigmented alveolar histiocytes. So these are examples of those histiocytes. So they have an eccentric bland nucleus and this vacuolated cytoplasm, meaning we do have an adequate sample. As a diagnostic class or this type of specimen, it typically doesn't have the highest diagnostic yield for cytopathology, but we are able to see, malignancy sometimes, infectious causes, including viral cytopathic changes, as well as other pathologies. This on the right is showing you an example of clustered pneumocytes. So whenever you're going through the air spaces, you can shed some of that epithelium from the air spaces out, but nothing atypical here to suggest malignancy. The interesting pathology that came up in this patient, which I guess I could go through some of the differentials. I noted that the patient had asthma. Hypothetically, you could see Cushman smilers or Charcot-Leyden crystals, which is something we associate with asthma. That's more common in the sputum samples, not so much in the BALs. In this patient's case, we had this amorphous material that's proteinaceous, amorphous, as I mentioned, kind of a glassy, homogeneous appearance. It's a pretty classic morphology for this entity. Something on the differential you could think about maybe is whether there's secretions or pulmonary edema, which probably would be more like foamy and granular. Could also think about infections if the patient was immunocompromised, such as pneumocystis, which once again, that's typically more of a foamy exudate. Once again, this stuff is pretty distinct, round, glassy, and homogeneous in appearance. And since we were kind of clued into the diagnosis based on imaging, they did a periodic acid shift stain, or a PAS stain, which was positive in this material, which pretty much cinches the diagnosis, which I'm happy to provide that. Or if you want to go for it, I know you're pretty on top of it. So
Yeah, let's hand it over to Dr. Chakinala for a diagnosis.
Yeah, I mean, I think this is a good description, and it's nice because the imaging and the path corroborate it. So I think this is a good PAP diagnosis.
yep, you got it.
Awesome. Thank you so much. And I just want to point out for time, let me just get this control back here. I'll just point out that we did have immunology that was sent, especially when you make this diagnosis. You'll often send an anti-GM-CSF autoantibody, and this became positive for anti-GM-CSF autoantibody. All right. So let's congratulate Dr. Chakinala for a correct diagnosis.
Thank you.
And I just want to point out very briefly, she was discharged on some PRN medications. Subsequently, she's undergone whole lung lavage 4 times. She's on open label inhaled molgramostim in 2023 with Dr. Anderson. She's had a marked improvement after lavages. She exercises regularly and is following along well. And just for a teaching topic, to point out very briefly exactly what Dr. Chakinala, Dr. Raptis, Dr. Morse were all saying. We have pulmonary alveolar proteinosis here. It's a rare disease. Most commonly, about 90% of the time, it's autoimmune. In that case, these IgG, antigranulocyte macrophage colony stimulating factors, antibodies decrease macrophage function. In the other cases, secondary, you can have direct inhibition of the macrophages. And then in inherited disease, sometimes receptors are abnormal on the macrophages or these antibodies. We don't have a causal link, but smoking is often found in up to 85% of cases. This case is somewhat unusual in that this was female, whereas males are more likely to be affected. And then diagnosis is often made later in life. We saw maybe a couple of things here, a bat wing distribution on the chest x-ray. And then again, this classic finding, crazy paving. Just lock that away in your heads for board exams with the intralobular thickening and the diffuse ground glass opacities. And then just as you might have it, our experts here at the Lung Center, Dr. Anderson, is following this patient. I'm happy to say that Dr. Chakinala agreed with his own PFT interpretation, which he actually did when the patient was admitted. And this patient is... the usual treatment is whole lung lavage and recombinant GM-CSF, which she's taking. They found that steroids are usually ineffective, and there have been some case reports and series to point out that rituximab may be helpful and plasmapheresis may be helpful. So just another round of applause for Dr. Chakinala. And thank you so much, Dr. Raptis and Dr. Morse, for all of your education here today.
Thank you, Carl. It's a great case.
Thank you so much.